Good evening. And the allogenic implant, the difference is here we are implanting extra tissue versus transplant where we replace. So this is a much easier way than transplant. Coming to the keratoconus, this ectasias, we tried 8 millimeter size to size of implant, 7 to 8 millimeters, 200, 300 microns, and a depth of 200, 150 microns. Generally, we cut with femto as shown by the Dr. Namrata Sharma professor, and we open up the pocket through the hinge. Generally, I put a temporal hinge, and the hinge is cut. Only thing is we switch off the side cut in the femto, so it's up. Or when side cut is starting, we lift the foot switch, and then the implant is inserted into the cornea, into the center. This works well in selected cases of central cone, not in the peripheral cone, which we commonly see in India. Inferior cones, it's not a very good technique. Central cones, we tried many years. We started almost 15 years back, and a few cases we tried. It looks nice. Initially, there will be some edema. Slowly, it clears, and in a few cases, topography. This is a pre-operative, and this is the thickness. Gradually, the edema subsides, as you know, as shown in the slides. Initially, it will show little thick corneas, 400 microns. Then slowly, it comes down over a period of time. The topography also improves. The flat portion, for example, in the extreme right, you see a flat cornea that becomes steeper, and steeper becomes flat, and there will be a lot of good regularization of the cornea. Topographically, it shows excellent results. What we learned is we tried a lot of things like very deep, very superficial, combined with C3R, without C3R, reversing the lenticule. For example, you cut the lenticule this way and reverse it, so that we thought that will flatten the cornea much better in the center. And different thickness, 200 microns, 150, 300, 400, like that. And what we learned is donor cornea should be dried, very well dried, in artificial antechamber. Instead of putting fluid, you put air in the artificial antechamber, leave the cornea for a certain period of time, so that it becomes dry and uniform. And topography results are very good. Visual results also improves. But early cases do better than the advanced cases. So what we learned in this 15 years, 10 years we started doing this is final outcomes are not very satisfactory. There's moderate to severe cases not doing well, and best corrected visual acuity is with spectacles is not very good in our hands. And the quality of vision is also not comparable to DALK, and DALK is a quite simple technique nowadays. So we shifted to DALK. So we abandoned this technique as of now. This technique. Next comes the PMD. This is a difficult proposition, because the cone is very much, you see here, 200 microns, 250 microns. At that stage, usually the patient comes. So in this case, the surgery is very simple here. Under topical anesthesia, make a cut at the limbus, and with a crescent knife, we can easily make a tunnel. It comes very easily. The tissue is very soft. It may take 1 to 2 minutes. Slowly you advance. You can go up to the opposite side and make a nice tunnel, and you are not touching the visual axis, unlike in the keratoconus, where we are opening and putting a graft in the visual axis. And make a hand-fashioned graft, 300 to 350 microns, trim it and insert into this. That's so simple, and no sutures, nothing. And you insert the graft slowly. It's nothing great in that. You insert and iron it out in the inferior portion, which is not a visual axis, so we are very safe here. And sometimes you put a suture, sometimes you don't. So from 200 we can bring out to much better in the inferior. They are very stable. The cornea becomes very stable, and this is the post-operative. It improves, but astigmatism doesn't change much, but it becomes a little bit regular. This is the pre-op, this is the post-op appearance, and these are over a period of few years. And this is our standard technique now. Routinely we do it for all our cases of PMD. And the advantage here is it stabilizes very well. PMD is a very slowly progressive condition, unlike keratoconus, and the residual astigmatism is also very good. I mean, even 10-15 diopters we can do customized phakic IOLs and implant and they do very well. The advantage, just a topical, no graft rejections, no suture-related astigmatism, and no requirement of long-term steroids. And a single donor can be used, or leftover cornea from DMEC, the leftover pieces can be used here in this case. And then comes the new kid in the block. That's the CARES, our own Dr. Susan Jacob. She promoted, she started doing this for maybe 5 to 7 years back. This is a nice technique. Here we are substituting PMMA with corneal tissue. It's soft and flexible, it's biointegrated, and no chance of extrusion, and can be placed superficially for better effect. Even terrible eye rubbers or young kids, maybe 8 years, 10 years, 12 years, we are a bit reluctant to do dark. We can try this technique. And different shapes, thickness, sizes can be customized for different patients and depending upon the topography for each patient. So here we make in femto 250 to 300 microns thickness tunnel. Then the central is usually 5 millimeters or 5.5 millimeters punch. Then periphery again around 7.5 to 8 millimeters punch. Then we hand fashion posteriorly depending upon the topography. Usually I take only one cut and put the button and put the ring and pushes into the segment. This is actually Intax channel maker. I had few in my OT. I use them to rotate these segments into that. It goes very nicely. Initial few cases we feel little bit anxious. After that it's very easy. It takes few minutes to pass this surgery. The superior one, sometimes we stop. Inferior means only superior. If it is a central cone, then we use a double, and sometimes we use 360 degrees depending upon the cone. And each segment we can do even asymmetrical. One can be thinner, one can be thicker depending upon the topography. These are the results. This is the inferior cone. This is the pre-operative topography, and post-operative topography. You can see very good regularization. And this is the 360 degrees for central cone. This is the pre-op one. This is the post-op. Here we little bit erred. We over-corrected and became more flatter, but visual acuity improved nicely in this case. And this is another case with a central cone and 360 degrees. We did a 320 here, and still a little bit we erred. We got a more flattening here, and this can be learned over a period of time. And this is the pre-op and post-op, this comparative up to 11 diopters correction. We cannot get with Intax 11 diopters flattening, which is fantastic with this. And very advantage with this CARES is this is the topography maps. For example, this case you see it here we fashioned with a thick almost 350 microns. Here we put a 150 microns superiorly. So we can fashion depending upon the topography, which side you want a thicker one, which side you want a thinner one, which one a thicker like that. We can play very well with the one. The other one below OCT shows equal size in a central cone. This is a very interesting thing. And the corneal ectasia, when it comes, I believe this is a defective collagen synthesis. Mesenchymal cells are the culprit. Whatever donor tissues we are putting, they are devoid of mesenchymal cells. We are not addressing the pathology. We are trying to correct only the anatomy. I feel still we are going in a wrong direction in all these treatments. And there are some studies where they are trying to do a cellularized donor corneas. I think that's the way to go. We have to cellularize these donor corneas with the human adipose tissue, derived stem cells, which is the easiest one and proven one so far. And it's a very interesting one. We are the experiences. We try to reason and analyze depending upon our experiences. As long as we try to analyze and reason it out, we never see the truth. It's only our experiences create something, and we cannot find solutions. We have to erase our mind, whatever we learn. Then only look at the mind with a fresh, like a kid, then we see. At this age, it may not be possible. Maybe we have to reborn to do this. Thank you very much.